of estrogen, progesterone, growth hormone, prolactin, insulin, and probably thyroid hormone, parathyroid hormone, and cortisol. This complex process typically begins between ages 8 to 14 and spans about 4 years. The breast contains mostly fat tissue, connective tissue, and glands that following pregnancy will produce milk. The milk is collected in the ducts and transported to 15 to 25 openings that exit through the nipple. During the menstrual cycle, the breast is smallest on days 4 through 7, and then begins to enlarge under the influence of estrogen and later progesterone and prolactin. Maximum breast size occurs just prior to the onset of menses. The breast is not round but has a tail of breast tissue extending up into the armpit. This is clinically significant because abnormalities can arise there just as they can in other areas of the breast. Breasts are never identical comparing right to left. One is invariably a little larger, slightly different in shape, and located differently on the chest wall. The nipples are likewise never identical but show minor differences in size, location, and orientation. The breast is divided into quadrants to better describe and compare clinical findings. The upper outer quadrant is the area of greatest mass of breast tissue. It's also the area in which about half of all breast cancers will develop. During adolescence, several breast growth problems can be troubling to the adolescent and her family. Among these are unusually early breast development, unusually delayed breast development, unusually large breasts, also called mammary hypertrophy, unusually small breasts, asymmetrical breast growth, and breast lumps. Initial breast development occurs on average at age 9 with the appearance of a breast bud. The normal range for breast bud appearance is from ages 8 to 13. It's common for one bud to appear up to 6 months prior to the second bud appearing. Breast growth is then progressive, with enlargement of the breast tissue, areola, and papillae, and change in shape and contour. By age 18, breast development is usually complete. Premature thelarchy is breast development prior to the age of 8 in the absence of pubic hair development. We evaluate these children to rule out estrogen-producing ovarian tumors, ingestion of estrogen-containing compounds, and the rare true precocious puberty. Delayed telarchy reflects absence of any breast development by age 13. Asymmetric breast growth during adolescence is the rule rather than the exception. Reassure the patient that the asymmetry usually evens out by the time of full maturation. Even at maturity, breasts are rarely 100% symmetrical, so minor degrees in asymmetry are expected. Because the breasts are continuing to grow and change, we usually delay any surgical intervention for asymmetry until after age 18. Mammary hypertrophy can be a distressing symptom. Because growth and development continues for a long time, if we are contemplating surgical intervention, we generally delay the surgery until the breasts are fully mature. Breast masses in adolescence are essentially 100% benign. Because of this, surgery such as excisional biopsy or fine needle aspiration is almost never warranted. Further, the surgical disruption of architecture can be disfiguring as the breast continues to mature. Supernumerary breasts are relatively common. They are found along the milk line extending from the axilla to the groin. Most of them are not noticed clinically until pregnancy occurs. Then, under the influence of the pregnancy hormones, the breasts enlarge in preparation for lactation. It's at this time that soft swellings along the milk line occur, representing supernumerary breasts. During lactation, the extra breasts may produce milk. These are not dangerous and are generally ignored. If they prove to be a cosmetic problem, they can be removed surgically. More common than supernumerary breasts are supernumerary nipples. Like extra breasts, these are located in the milk line and are not dangerous. Unless they are large, they are usually not noticed until a pregnancy, and at that time, like the normal nipples, they enlarge and darken. Usually nipples point outward. Sometimes they invert. When they persistently point inwards, they are called inverted nipples. This can be unilateral or bilateral. With stimulation and nipple erection, most inverted nipples will evert. Occasionally, they remain inverted despite all efforts to evert them. Other than for cosmetics, nipple inversion is not usually a problem. For breastfeeding, most inverted nipples will evert. Even those that do not evert may still function normally enough to allow for satisfactory infant nursing. Among the common causes for non-cyclic breast pain are trauma, infection, and chest wall pain underlying the breast tissue, in other words, muscle strain or overuse of the pectoralis major muscle. Breast cancer rarely causes breast pain in the early stages and is not usually suspected unless the symptoms persist. Hormonal causes include functional ovarian cysts and pregnancy. Women complaining of non-cyclic breast pain should have a careful examination. Common areas of tenderness include the pectoralis muscle distribution over the anterior chest wall. In this case, the muscle itself will be sore, and the breast, if palpated with two hands and not pressed against the tender muscle, will be non-tender. Pain or soreness in the pectoralis major muscle is frequently found among women who have recently engaged in strenuous physical activity, and it represents a muscle strain. Chest wall pain does not involve the nipple or areola, while cyclic breast tenderness usually does. Treatment is symptomatic with rest, some stretching exercises, and non-steroidal anti-inflammatory medications such as ibuprofen or naproxen. A second common area for chest wall pain is along the costal margin. Direct pressure on the costochondral cartilage without compressing the breast tissue will duplicate that pain. Compressing the chest wall with your hands placed laterally to the breast will also duplicate the pain. This costochondritis has similar etiologies to the pectoralis major muscle tenderness, and the treatment is the same. If the pain persists, referral will likely be necessary. Trauma can include vigorous coughing or vomiting. The resulting strong, sustained contractions of the intercostal muscles can lead to chest wall tenderness that may be perceived by the patient as breast pain. Now a few words about cyclic breast pain. During the days leading up to the normal menstrual flow, the breasts normally are somewhat engorged and may be somewhat tender. Following the onset of menstrual flow, these changes spontaneously resolve. If the tenderness is more than mild or is clinically bothersome, it's called cyclic breast pain or mastodynia. If you examine the patient during this time, these women also often have significantly enhanced nodularity of the breast tissue. The combination of cyclic breast pain and symmetrically thickened nodularity of the breast tissue is often called fibrocystic disease, although that's a misnomer because it's not really a disease, or fibrocystic breast changes. While it's not dangerous, women with cyclic mastodynia find it annoying, and in its most severe form, it interferes with some normal activities. Some women find that by reducing or eliminating their intake of caffeine, such as is found in coffee, tea, or cola drinks, and taking vitamin E supplements, 400 IUs per day, has seemed to improve their symptoms. Whether such improvement is pharmacologic or placebo in nature is still under debate. Any pharmacologic approach that suppresses ovulation will be very helpful in treating cyclic mastodynia. Among these, birth control pills are the simplest. Taking birth control pills in the usual fashion generally improves the pain significantly. For those who still experience significant pain, continuous birth control pills will usually suppress the pain completely. Also effective by virtue of ovulation inhibition are depomedroxyprogesterone acetate, Lupron, or Danacrin, the latter two usually justified only in severe cases due to their significant side effects. Nipple discharge. Normally, if the milk ducts are stripped towards the nipple, a drop or two of clear, milky, or greenish-tinged liquid will appear. This is not considered nipple discharge. If the nipples spontaneously leak discharge, staining the clothing, that's not normal, nor is it normal to have bloody nipple discharge. Nipple discharge from both breasts indicates galactorrhea. While a few postpartum women will continue to leak small amounts of milk for years following delivery, galactorrhea in general indicates the need for a serum prolactin measurement and possibly an MRI of the pituitary gland to look for prolactin-secreting pituitary adenomas. Hypothyroidism can also cause this problem, although that's rare. Athletes may experience small amounts of galactorrhea from constant rubbing of the nipples against clothing. Frequent sexual stimulation of the breasts may have similar effects. The serum prolactin measurement is best made after a few days of non-stimulation of the breast. Even after a breast exam, it is often helpful to wait 2 days before measuring the serum prolactin.